So now I think the next speaker is Anthony Philippakis. And Anthony is Chief Data Officer at the Broad and also co-director of the new Eric and Wendy Schmidt Center for Machine Learning. Anthony, please.
Thank you so much. It's such an honor to be here and participate in this great session today. Hopefully everyone can see my screen, it's just loading. As Colin mentioned, I'm the Chief Data Officer at the Broad and responsible for the data sets and software produced at the Institute. And so today I'm going to be talking about things more as it relates to sort of data infrastructure and data technologies rather than specific machine learning approaches. However, a real focus of a lot of things that we're doing is increasingly related to public health. And in particular, the three vignettes I'll be talking about today, I really hope speak to some level of health equity as it relates to both socioeconomic status, geography, and ethnicity. So, to motivate a lot of what follows, I always kind of like to look at a historical view on things. And, it's amazing to think that I'm a physician, I'm a cardiologist. And when my grandfather, who was also a doctor, practiced, medicine wasn't really a science. We didn't have a good understanding of what therapies worked or really have good rigor or, quantification of why. And the branch of medicine that really kind of focuses on changing the state of affairs is epidemiology. And where did it come from? It actually goes back to a period in Victorian England. And one of the original pioneers was Florence Nightingale, who not only was the founder of nursing, but was actually also a very good data analyst and collected a lot of data on causes of mortality during the Crimean War, and actually showed that things like poor sanitation and overcrowding were much larger causes of mortality than, in fact, the war itself. A second hero of this area was Jon Snow. And I do want to stress, Jon Snow is a Victorian England character, not Jon Snow from Game of Thrones. But this was a time when there were a series of cholera outbreaks throughout the city of London. And in one of the worst ones, he very painfully tracked where the cases were and actually traced it back to an infected water pump. It was then removed and actually did a lot to remove the cause of that epidemic. And of course, a little bit later on, the great Archie Cochrane, who's someone who really spoke to the idea that we should create, evidence for what therapies work and why. So now, against this backdrop of a series of people in England that kind of started off the field, now we live in a very different time. And I think it's interesting to ask, what should epidemiology look like in the 21st century? And certainly we have a lot of new technologies at our disposal, whether it be new ways of assaying physiology and monitoring it long-term, or lots of genomic technologies, which of course are an area of emphasis at the Broad. Similarly, we have lots of new data technologies, things like machine learning and cloud, which are very much the focus of this. But one of the things that I want to argue is that while we have lots of new tools to go after questions of health equity in epidemiology and public health and beyond, many of the same questions actually still remain. Namely, how do we monitor disease incidence and prevalence? How do we track the spread of infectious disease by doing surveillance so that we can design interventions? And then how do we better design clinical trials? And again, in all three of these, there's a lens towards having much greater health equity than we've had in the past. So let me start with incidence and prevalence of human diseases. So All of Us is an effort that launched about 3 years ago to recruit 1 million or more research participants from across all of the US, to follow them longitudinally, obtain full medical records, genome sequences, and then return results to all the participants. Importantly, one of the things that's key to this effort is that all researchers get access to the data sets at the same time. And to quote the director of the NIH, this is one of the most ambitious efforts that our country has ever taken. It can very much be thought of almost like a Framingham heart study for the 21st century. So recruitment was launched in a soft launch in July of 2017, and then an actual full national launch almost exactly 3 years ago. And the hope is that by about 2 years from now, or a little less, we will have succeeded in recruiting 1 million or more participants. Now, one of the things that All of Us is especially commendable for is its emphasis on recruiting people that were traditionally underrepresented in biomedical research studies. So more than 80% of the participants are from UBR communities, and more than 50% are from racial and ethnic minorities. And so when we think about the classic question of better understanding the incidence and prevalence of human diseases, this is a very powerful new cohort to address a very old and important challenge. Now, another thing that is innovative about the All of Us effort is its approach to making the data available. So as I mentioned, all data collected as part of All of Us will be made available to all researchers on equal footing. There's no group of investigators that are part of the All of Us community that get privileged access to the data. But one of the things that the approach to doing it is a bit different. You know, traditionally, a lot of important cohorts that were in health data would be put on a server, and then we tell researchers to download them to their own environment. This creates several challenges. The first is that in order to be able to share the data, you have to copy the data. And then this is very expensive because you end up storing a copy of the data set at essentially every medical center. Then second, when you download data, it's very hard to track and audit who's touched it and for what research purposes. Third, it leads to a lot of disparities among researchers because in order to even begin to work with massive genomic and clinical data sets like All of Us, you would have to be at a well-resourced institute. I think we all realize that there's a long tail of researchers that could make great advances if only they had access to the data. And then finally, we need to have elasticity in our computing environment. And again, so by inverting the model so that instead of downloading the data, we place it on a public cloud where researchers can get access to the data where it's co-located with compute and storage, we address many of these traditional shortcomings. So the data is already available with more than 300,000 participants and 200,000 with EMR data. In the second half of 2021, the genomic data will start to be added. And again, we hope that this will be a great resource, especially again, for investigations that are populations that were traditionally UBR. And many of the projects that are underway and getting published now, in fact, do focus greatly on health equity, which is quite exciting to see. So then let me talk about a second effort. And again, Terra is the data platform. This is made by my group at Broad that underlies all three of these. And this speaks to infectious disease surveillance. So here, again, it's really important to note that the burden of infectious diseases is not uniform around the world. And particularly in many developing countries, there's an incredibly large burden of infectious diseases. Many of my colleagues at the Broad are trying to continue the work of John Snow that I mentioned before by continuing to work on new methods of doing infectious disease surveillance, again, with a special emphasis on developing countries. One of the initial proof points of this was the 2014 Ebola outbreak, which took place in Western Africa. And at the time, it wasn't clear whether the transmission was from animal to human or from human to human. And by doing a series of genome sequencing on about 100 people, and again, these samples were obtained at great personal risk, they were able to show that the human-human transmission was dominant. And again, shows the potential for doing a new kind of contact tracing with much greater resolution than we've done before. Being able to tell where infections come from, are they local or through the result of travel? Also being able to monitor for resistance mechanisms. And then finally, as we better understand how the disease spreads through a population, can we design interventions to measure their impact? So again, at the other side of this, many different funding groups started to call for greater use of genomics in infectious disease surveillance. These range from government organizations like the Nigerian Center for Disease Control to international bodies like the World Health Organization, and then finally philanthropic groups like the Bill and Melinda Gates Foundation. And again, key to these efforts is that while the data is generated all over the world, you need to be able to have a place where it becomes aggregated and shared with researchers everywhere. So working closely with my colleagues at the Broad Institute have launched two efforts very much focused on infectious disease surveillance in the developing world. One with an emphasis on epidemic preparedness, which launched 18 months ago. That was actually before COVID was even known about. And then another one that's just getting going now on malaria surveillance. And actually, one of the things that's quite exciting is that although the funding was not initially meant to focus on diseases in the US, actually, we were able to re-leverage this funding source and actually have an impact on COVID. Quite a bit of COVID sequencing is now happening at the Broad. And in fact, this platform is also being used by many different departments of public health, as well as the CDC at sites around the country, to make it much easier to run pipelines on COVID samples as they're sequenced, and then of course make sure that the data is shared with researchers everywhere. And again, it speaks to the potential of building out a future world where we are able to track the spread of diseases across time and space, much like the way that we currently are able to be able to track how people move throughout the world across airlines. And then finally, let me talk about a third area that's of special importance, which is designing clinical trials to get further evidence on what diseases work and why, and in particular for what populations. So let me give one example of the current state of affairs. And again, what really need to speak to improve health equity. So PCSK9 inhibitors are a new class of drugs that have just come out in the last 10 years that are very much focused on preventing MI by lowering LDL cholesterol. So here's one of the first studies that was run, the so-called Fourier trial, which had 27,000 patients and was run for 3 years at a very, very high cost. And what you see is that the event rate is quite low. Only about 15% of people had a heart attack in the trial or related disease, which means that 85% of the trial is wasted. You just don't know which part. Moreover, the effect size was rather small. The hazard ratio is 0.85, which means there was only a 15% relative risk reduction. So what if it was possible to select patients for the trial so that the event rate is increased and the clinical response is also increased? So some work by my colleagues at the Broad Institute really showed that polygenic risk scores are a very powerful tool for doing this. At the right, if you take people who are at very high genetic risk, then you see that in fact you can both increase the event rate and increase the response to treatment. However, the state of affairs is very much in its infancy, and a real problem for many groups around the world is that so many of our genetic samples are collected from non-diverse populations. And what that means in practice is that our ability to predict disease based on genetic risk works much better in European populations than many others. So this is a state of affairs where there's urgently needed change. And again, many geneticists around the world are developing a new generation of methods to try and greatly address this. So with that, I'll close out and thank many of my colleagues that I've worked with on these 3 different efforts, whether it be all of us, infectious disease surveillance, or clinical trials. Thank you.